You are in tune with the nation's stations, ABS TV Channel 10, the GIS, and ABS Radio 90.5 FM. Proudly serving you, reaching more and more people every day. You are in tune with the nation's... Good evening. Thank you so much for joining us for another edition of House Calls. Another epic edition of House Calls awaits you this evening. We're focusing this evening on how to be your best self, living longer, being healthier, being well. Okay? Because sometimes we get confused with being healthy and being well. We want you to be not just the absence of disease, but we also want you to be well. So that's our focus this evening on House Calls. And, you know, the idea, for example, of life expectancy, thousands of years ago, things that we take for granted these days, to be able to just take a quick antibiotic and get rid of it, that was a major cause for challenge thousands of years ago because there were not these advances in medicine. So life expectancy, if you reached to probably 40 or 45, you'd consider yourself lucky. Now we're talking about life expectancy in the 70s and so on. So that's a good thing. So we've seen the benefits of advancements in healthcare and in medicine and in technology. Know-how, human civilization, that advancement, that know-how has really inured to the benefit of mankind. But how do we ensure that we use that know-how to ensure that we live not only a longer life, but a healthier life and a life of wellness? And so, joining us this evening, the doctor in the house, Dr. Jason Belazaire. He is a consultant physician. He is head of medicine at the Celeste Bird Medical Center and also a specialist in internal medicine. All right? A lot of hats Dr. Jason Belazaire wears, but all of which are germane to our topic this evening about living longer. And so we're going to be talking about the diseases in the country which account for most of the deaths in the country, and how do you ensure that you minimize your risk of having those diseases and having a bad prognosis. So, good evening to you, Dr. Jason Belazaire. Really appreciate you joining us this evening.
Thank you. Thank you for having me back.
Indeed. And Doc says back because he's actually been on House Calls before, so he's making a return visit on House Calls. Doc, just for the audience who might have missed your first appearance, just talk with us a little bit about, just introduce yourself to the audience as being the doctor in the house this evening.
Okay, well, I am an Antiguan, been living here since 1969, came back in 1998 and started work at Halberton Hospital, left for a while in 2006 and then went back to Mount St. John's in 2014. I'm currently the head of medicine at Celeste Bird. I have my private practice and some other interests, and consider myself blessed. Indeed,
indeed. And just very quickly, why internal medicine? You could have done so many other different disciplines, I suppose, in medicine. Why that one?
I felt that was the most challenging. You know, I think that is what you go to medical school for. That's what you spend the majority of your time studying. It's probably the least glorious of the specialties, but the vast majority of what enters a hospital on any given day. I mean, you've got 5 major specialties in medicine. You've got surgery, obstetrics and gynecology, pediatrics, psychiatry, and then, of course, all the other stuff tends to fall into us. All the heart attacks, strokes, ulcers, kidney stones, all those other things tend to fall under us. So, you know, to me, it's the most challenging.
Okay. And so Dr. Belazaire immersed himself into as I said, internal medicine. All right, so I mean, he's appropriately best suited to talk about this issue now about how to ensure that you live longer, that you avoid the pitfalls of, for example, not being screened properly for certain diseases, and so on. So, Doc, you'll start off, because you've prepared for us an extensive slideshow, we'll start off by looking at some of the particular challenges, the diseases which are accounting for most of the deaths in this country. Over to you.
Yes. If we can put up the first slide there. The last year that I could find statistics for was 2012. When you look at what people die from in Antigua. It varies between heart disease and malignant neoplasm every year. In other words, those are usually number 1 and number 2. When you look at number 2, number 3, number 4, and number 5, which is heart disease, diabetes, cardiovascular disease, hypertensive disease, those 4 diseases all tend to come from the same sort of problems, which is clogging up of the arteries, whether it is from diabetes, high cholesterol, high blood pressure, heart disease. The pathology behind heart disease and the pathology behind strokes are very similar. Okay. It's blocking up arteries, clots that break off. Those 2 real areas, because I tend to group number 2, 3, 4, and 5 into cardiovascular diseases, by and large make up the majority of what people die from.
2 to 5.
2 to 5,
right.
And then of course you have number 1, which is cancer. Malignant neoplasms is all the various types of cancer. Mm-hmm. I want to focus tonight really in talking more about screening and the screening tests that we do for cancer, but I'm going to touch a little bit on the heart disease. Because I know these topics were covered by some of your previous speakers,
absolutely,
I want to provide some newer information.
Very good, very good. If we could just go back to our slide there, because that is extraordinarily instructive in terms of what do we know about the situation here. So disease of the respiratory system, way down, so cardiovascular challenges, cancer, heart disease, well, cancer and then cardiovascular challenges account for most of the deaths.
Correct. For about, if you go to the next slide, it covers about 66%. In that particular year, we had 493 deaths, more males than females, 21% from cancers and 45% from heart disease, strokes, diabetes, hypertension, what I call cardiovascular diseases. And so if those 2 things make up 60%, 66%, nearly 2/3 of the cause of deaths in Antigua. And there are things that we can do to improve our odds of living longer in dealing with these diseases.
Extraordinary, extraordinary. I said it at the top of the program, Dr. Belazaire, that thousands of years ago, ancient man had to be contending with some things that we take for granted these days. We just go to the doctor gives us an antibiotic, and we're good to go again. I mean, but before antibiotics came on the scene, some relatively simple things that have killed people. So our life expectancy has gone up as a result of that. But even though we have made these advances in medicine, there's still challenges. These things are still killing a lot of people. I suppose your message this evening, Doc, is that some of these things are preventable if we act differently.
Correct.
Wow.
You know.
Wow.
And if we start with the heart disease part,
yes.
I mean, what are the things that we need to do to improve the cardiovascular risk? Well, we've got to eat right, exercise regularly. We've got to adjust our diet. Our diet is too full of carbohydrates and things that are making us gain weight and become obese, as well as develop diabetes, hypertension, these sort of things. We've got to stop smoking, exercise. You know, the new recommendations on exercise are 150 minutes of moderate intensity exercise or 75 minutes of high intensity exercise a week. And so we got to try and get to some of those goals, bring our weight down. If you're on medications, got to take your medications. If you want to survive cardiovascular disease, we improve your odds of living with cardiovascular diseases, hypertension, diabetes, you got to take your medications. You got to see a doctor regularly, and you got to take your medications. You know, and that is a huge problem in Antigua. We have great medications provided to us, some of the best medications in the world. I don't know if we realize just how fortunate we are, but a lot of the time, the patients just don't take them.
Why don't patients take the medication now? I mean, is it that they don't remember? Is it that they think that it doesn't help them? Is it that they think that the doctor made a mistake in prescribing a particular medication? What accounts for that?
I mean, all of those things. You know, some people are fearful of medications. You know, some people don't like taking them. Some people are worried about side effects. Some people get side effects, but if you get a side effect from a medication, you got to talk to your doctor about it. You can't just say, well, I'm not going to take my blood pressure pills today because today might be the day that you end up with a stroke or a heart attack or something like that. And that's where the dialogue with the doctors comes in, you know. If you're taking your medications, you're having a problem, you've got to tell the doctor about it. There are things, medications do have side effects. We know what they are generally, and so we can adjust, change. You know, not everybody falls into, not everyone gets the same medications, because not everyone has the same problems.
Yes. And I suppose you'd wait on balance, you do a cost-benefit analysis, that the side effects are there inevitably, but not taking it, the risk of not taking the medication is far worse than the side effects.
Correct. And you know, there are very few things that we can do, that we can, as doctors, that can say, well, this will make you live longer. You know, we know that people who have high blood pressure, who take their medications, will live longer. We know that diabetics who take their medications will live longer. People with high cholesterol who take their statins will have fewer heart disease, fewer heart attacks, fewer strokes, and will live longer.
Yes.
You know, that's a rarity, really, in medicine. And we're still trying to prove, you know, some of the stuff that we were talking about, giving people antibiotics for certain infections. The trend nowadays is to give less and less, because we're finding that, you know, we don't need a week of antibiotics. Sometimes 5 days is enough. Sometimes 3 days is enough. But even with a lot of infections, there are a lot of times where the things that we do don't necessarily make you live longer. But when it comes to cardiovascular disease, diabetes, hypertension, you know, high cholesterol, those sort of things, we can show that we can make you live longer as a whole. And so if 46% of our deaths in the country come from heart disease, and we can address that, well, you know what, you're going to live longer. You know, but I really wanted to talk more today about cancer screening and what screening for cancer really is about, because yes. I get people constantly coming and asking me, well, Doc, I need to do a test to tell me if I have cancer. You know, what cancer?
That's rather simplistic.
You know, all cancers. I just need to know, you know, what kind of, you know, what can I do about cancer?
So they think that there's one test that can tell them if they have any cancer.
Well, you know, they'll come in, they'll ask for, you know, can I get a full body scan? You know what I mean? And you know, those things generally don't work.
Yes.
We end up picking up problems that are really not problems. But once you see something, sometimes you're duty bound to investigate it to make sure it's not a problem, and that raises the cost of medicine and really doesn't make anyone live longer. But
extraordinary, Doc. We're going to take our first break shortly, but just before we take our first break, I want to get through a few of the other slides, because you've done an extraordinary job in collating for us the information. I mean, just the statistic there from our first slide. If you could, Damien, go back to that first slide with the list of causes. I mean, that's extraordinary. 103 deaths from cancer, and this was in 2012.
Yes.
Just in 1 year alone. That's really extraordinary. 95 deaths from heart disease. So you have to protect your heart health. I mean, not just heart disease, but diabetes and cerebrovascular diseases, hypertensive diseases, all those cardiovascular matters, you have to protect that. So that's extraordinary. In all, over 400 deaths recorded in that year, 2012. I'd be very interested to see what the figures are for 2019 to let's say last year. But of course, hopefully those will come at some time soon, right?
No, they will. I mean, I'm sure they know them. In all honesty, I didn't go asking for them, because I think they're going to be skewed. Right. Obviously, with our 130 COVID deaths. Yes. You know, they're going to be skewed somewhat.
To the respiratory. So the respiratory deaths would, for example, go up as a result.
And that'd be interesting. It depends on how they would classify it. Whether they would classify COVID. You know, with COVID, you know, we have respiratory deaths, but we also have stroke deaths. We also have heart deaths. We have kidney failure deaths. So we have diabetes deaths, all mixed into there, because let me tell you, when COVID hits the system, for some people, it can affect diabetes, heart disease, strokes, increases the risk of all of that. And one of the things we're seeing now is that people who've had COVID, even mild COVID, their risk of heart disease, their risk of diabetes, their risk of kidney problems are increased. And it doesn't really relate necessarily to how severe their disease was. They could have had mild COVID. Their risk of heart disease and stroke goes up significantly over where they were if they hadn't had COVID.
Extraordinary. It's really a multi-system disorder.
Yes, it is.
Extraordinary. So let's go to a few or other slides that Dr. Belazaire has provided for us, and then we'll take our first break. Damien, could you go to the next slide, please? So remember, the program is really about what do you need to do to live longer. Yes, Doc?
All right. So we spoke about these with this particular slide. Eating right, cutting down the carbohydrates in your diet, because those are our most calorie-rich foods that we eat. I'm an old-fashioned doctor. I believe in getting your vitamins the old-fashioned way. Mm-hmm. I don't believe in a lot of supplements. I believe eat your vitamins. Eat your fruits and vegetables. Get your vitamins the old-fashioned way. Exercise, we spoke about earlier. Stopping smoking, a big part of a healthy lifestyle. Taking your medications and seeing your doctor regularly.
The smoking there, is it just tobacco smoke?
No, all smoking.
So any smoke?
Yes, tobacco, marijuana, you know. Smoking is generally not good for you.
Yeah, there you go. So for our audience, smoking anything is bad. Tobacco, marijuana, anything else that you smoke. Whatever other leaves that you... There's a leaf that people chew in some cultures. Is that bad too?
Tobacco.
There's that, and there's another leaf that is also chewed as well.
I'm not sure about the other stuff, but chewing tobacco increases your risk of mouth cancer. And so, again, that's not a good thing to do.
Okay, there we go. All right, so our next slide now will show us, so there you go, living longer, you have the prescription. So cancer now, this will give us a sneak peek, and then we'll come back for details after the break. Yes, okay. Doc, what cancer?
So, well, cancer screening, you know, what does that mean? You know, when people come into me, oh, doc, as I said, they want the one test that'll tell them whether or not they have cancer. It doesn't really work like that.
Yes.
We doctors, we don't go looking for a cancer that we can't do anything about. Mm-hmm. You know, we're looking for cancers. When we talk about cancer screening, we've got to be able to do something about it. We've got to be able to save lives. It's got to be cost effective, and we have to be able to save lives. We don't go looking for brain cancers or pancreatic cancers because invariably our treatments have not advanced well enough that, one, we could find it early enough, and two, we could prevent their death.
Okay.
You know, a screening test needs to be safe, cost effective, and as I said, we only look for cancers that we can do something about. And then I'm going to go through the list of what those are, and some of them I'm going to go through quickly. I want to spend my time concentrating really on two of them that are not well spoken about, I think.
The two cancers? Two
of the cancers there that we show.
All right. So there you have a sneak peek of what Dr. Belazaire will be taking us through. I mean, as I said, every week we have a doctor in the house who brings their extraordinary knowledge, expertise, you know, cultured and honed over decades of practice and study to share that insight with us. And this evening, Dr. Belazaire, we're delighted and privileged to have him with us. I mean, sharing, such a treasure trove of knowledge and experience with us. So we're getting you to live longer. That's the focus. That's the thrust of our discussion this evening. How do you live longer and healthier? Not just living longer, because sometimes you can be living longer and you're really not healthy. So how do you live longer, healthier lives? We come back much more on House Calls. The program is sponsored by Sagicor, with kind compliments of Pink Mongoose and A.G. Morgan. We do appreciate your company, whether you're joining us on air or online. When we come back much more on Living Longer. Stay with us.
Life moves fast. Be prepared with Sagicor. Learn more at sagicor.com.
Antigua Barbuda Today brings you more on girls in ICT with Ilya Spencer. Wesleyan Youth District celebrates its anniversary, Menace Fitness Jam with Dennis the Menace, and Easter festivities in Parham. This and more, it's all here.
Seeing is experiential. Seeing is everyday life. Seeing is style, class, and sheer sophistication. At iMobile Vision Care, we offer state-of-the-art lab technology and the widest variety of quality eyewear from the biggest brands to suit your lifestyle. Stop by our offices at Dr. Rosalie Drive, Lower Gambles to get a comprehensive digital eye exam, or call us at 562-7823 and ask about our optical care services. iMobile Vision Care. See and be seen.
Welcome back. You're in tune with House Calls, a Tuesday evening program that is epic on all ABS platforms. It is must-see television, must-listen radio. It is ensuring that you are able to live better lives, healthier lives, be well, not just absence of disease, but actually being your optimal self. That's what the program this evening is specifically about, actually, living longer. We have with us Dr. Jason Belazaire, who is a consultant physician. He's a specialist in internal medicine and head of medicine at the Celeste Bird Medical Center. He's sharing with us on the diseases which account for most deaths in this country, and he's going to be zooming in now on cancer. Doc, over back to you.
Okay, so we can put up our next slide there.
Right.
Who makes the recommendations of what cancers we go screening for and how we go screening for them?
Right.
Most of these come out from the United States. The USPSTF is the United States Preventative Services Task Force, which was created in 1984. It's an independent body. It's a volunteer panel of national experts, and they use evidence-based medicine to decide what works and what doesn't work.
Yes.
They're still a little controversial because in medicine, not everyone always agrees. But there's the American Cancer Society, and then there are all the different specialty bodies. You know, the gynecologists have their group, the medicine people have their group, the surgeons have their group, and, you know, so they're all different bodies that come up with their own recommendations. But the main one, by far and large, is the USPSTF.
Okay.
Okay?
So they determine what are the ones that are screened for.
What we recommend people screen for.
There you go. All right. Or next
So
slide
the first one I'm going to talk about quickly is cervical cancer screening. I know this was covered by some of our previous guests. The recommendation from them is for cervical cancer screening with cervical cytology alone in women aged 21 to 29. And then as you get older, they recommend the cervical cytology, which is your pap smear, and high-risk human papilloma virus testing, which I'm not sure if we're doing that here or not.
Right.
But that's what they recommend that you do. And you can actually, if you're doing both of them together, you can do it every 5 years. Okay?
So just walk me through the different age ranges. 21, women 21 to 29?
21 to 29, and then 30 to 65.
Okay, so for the ones who are 21 to 29, they need to do every 3 years?
Just a pap smear every 3 years.
Right.
And then after that, between 30 and 65 years, every 3 years if you're just doing a pap smear, or every 5 years if you're doing a pap smear or high-risk human papilloma virus testing.
Oh, I see.
And if you're doing both of them together, still every 5 years.
Okay, there you go. That's,
Okay.
that's cervical cancer. Okay, good.
So I'm going to move on from there and go on to our next cancer, which is prostate cancer. I thought this was an interesting slide, really, because we're dealing with men, and you can see it's by and large the most common cancer in men. 19% of all cancers in the United States in men are prostate cancers. However, it is not the most deadly. If you look at the side below, in the US, it's about 8% of all cancer deaths. Lung cancer is the #1 killer of both men and women in the United States. It's interesting because in my experience here, I wouldn't say that it is the #1 killer of both men and women in terms of cancer here. I'm not sure if that is because our tobacco smoking rate is lower. You know, it hasn't really, we see a lot of lung cancer. Maybe it is that they don't live long enough. We just don't have them around for long enough. But it'll be interesting to see our cancer deaths broken down into what type. Number 3 on the list, colon and rectal cancer. But what I want to really get from that, and you're looking at men, when you look at the estimated deaths, we can screen for lung cancer, we screen for colon cancer, and we screen for prostate cancers, which are the top 3 cancers that cause death. So those things we are able to do a better job on, we are able to find early, and we are able to treat.
Okay.
And so we're going to talk a little more about
And by the way,
that.
these figures are for the U.S.
Those are U.S. figures.
Do we know what year this is?
I don't know.
Okay, but it would have been a recent
But it
year.
was recent,
Okay,
yes,
okay,
certainly within 2010 and after.
Okay, good.
Okay? So what are the risk factors for prostate cancer? Age. The incidence of prostate cancer rises rapidly after age 50. Over 60% of the new cases diagnosed in men are over age 65. A family history of prostate cancer more than doubles your risk. If you have a first-degree relative with prostate cancer, you're twice as likely to get prostate cancer.
And the first degree relative would be like a father, brother, or so on.
Father, brother, sibling.
Okay.
I mean, not sibling, child as well.
Okay.
Generally is what we call a first-degree relative. A brother greater than a father.
Right.
In other words, if your brother has prostate cancer, you're more likely than necessarily if your father had it. But it still raises your risk.
Okay.
Multiple relatives, if you have multiple relatives with prostate cancer, that increases your risk over if you just have one relative. And same thing, multiple generations at an early age versus a single generation at an older age.
Right.
So these are your risks. Being African American, you are more likely to die from prostate cancer than Caucasian men.
Now, why is that, Doc? Because that always
And
puzzles
West
me.
Indian men.
What is it about that?
West Indian men, I think, have probably the worst rates dealing with prostate cancer. And we're not sure why that is. Whether it is a genetic component, a dietary component. But the one thing that we do know is that it is a fact. West Indian men get the most aggressive, deadly type of prostate cancer known to man. And it's quite interesting because if you go to my next slide, there's a lot of controversy. The U.S. Preventative Task Force
Right.
actually made a recommendation a few years ago that doctors in the U.S. should stop screening for prostate cancer.
Extraordinary. Well, by the way, our control room will put up the next slide, as I said, that Doc is talking about. Why would that be the case now?
Because they found that they were over-treating. You see, prostate cancer is generally a slow-growing cancer. Their population is very different than our population. And so they felt that there was too much over-treating, that there wasn't enough evidence that treating the prostate cancer in their population made them live any longer.
I see.
And that too many biopsies and too many other procedures were being done on men where it wasn't going to make them, that wasn't going to kill them. That caused a huge uproar because, you know, if you do that, it puts us black men at greater risk.
Precisely, if you cut down on screening.
Yes. And we get that worst type, but of course we don't make up the majority of the U.S. population. And so that's why I'm saying it's somewhat controversial, because if you look at if I get a question on my U.S. board exams, the answer is no screening. Don't do anything at all. Interestingly enough, at least in internal medicine, the studies have come out to show that the rectal examination is not a very helpful test in screening somebody for prostate cancer.
So that's the one where the finger is inserted into
that's
the
correct,
anus?
into the rectum, yeah. So my male patients are very happy. We just do the PSA, no need for the rectal for screening for prostate cancer. We do rectal exams for other reasons, but as a screening test for prostate cancer, no, we don't do the finger anymore.
Okay, so this is a crucial part of this discussion, Doc. You're saying that right now in Antigua and Barbuda, and this is all doctors, the medical professionals, so internal medicine, urologists, etc.
No, the urologists won't agree.
Oh, they're going to still do
the urologist will still want their rectal
I see.
examination.
That's what I was getting at.
But if I answer the question on the test, the correct answer to the question is no rectal exam as a screening test for prostate cancer, at least in an internist or a non-urology standpoint, is not a good enough test. It's not helpful.
I see.
Do the PSA.
But urologists still want to do the digital
Yes,
rectal
I'm
examination.
sure they will.
I see, I see. All right. So as it is now in Antigua and Barbuda, digital rectal examination is still part of the recommended screening process.
I don't do it in my daily practice.
But for
as a screening
urologists, they
test
do
for prostate cancer, no, I don't. I think it also turns off men from going to the doctor. If they know once they hit 40 or 45, every time they come in, they're going to get a rectal exam. I think a PSA test is sufficient, and it doesn't scare the men away.
And that's PSA is
And there's no
prostate-
evidence. And the key
Yes.
really to it is that there is little evidence that it benefits men.
Okay. PSA is prostate-specific antigen.
No, the PSAS is a PSA test is good.
Right.
The rectal doesn't help.
I see, right. And PSA is a prostate-specific antigen which looks for particular things in the prostate that would be problematic.
Correct.
I see. All right. That is a simplistic way of saying it, but a simple way of getting it. All right. So Doc, so that's prostate cancer. And in terms of the timelines that we're looking at, when men should start screening?
Again, they will tell you in the United States, start at age 50. I would say here, I usually do a first PSA at age 40. Probably one halfway between 40 to 45, and every year from 45 onwards.
I see. Okay. All right. There you go. So our next slide now, Doc, will talk with us about more.
So I'm going to move on from prostate and go into breast.
Right.
About 1 in every 8 women will develop prostate cancer in their lifetime.
Breast cancer.
Breast
Right.
cancer in their lifetime.
Mm-hmm.
It's the second leading cause of death in women, generally second only to lung cancer. But the survival rates with early detection is high. So how do we go about getting...
1 in every 8.
Yeah,
Wow, that's high.
that is high. But that's over the course of a lifetime. And so it's a very common cancer and a very treatable cancer. And so I encourage women, the screening test that we're talking about is generally a breast exam. I encourage the women to do their own self-breast exams because I think they're far better and more likely to pick up a lump than we the physicians are.
Right.
And a mammogram. Now, the mammogram screening differs. Again, we have so many bodies coming out as to what should be done. Whether should it be done every year? When do you start? Should it be every 2 years? Generally here in Antigua, if you are average risk for breast cancer, we've been doing mammograms, or at least the hospital has been doing mammograms on a biannual basis, so every 2 years. The American Cancer Society recommends yearly mammograms, and we can put up the slide, starting at age 45 to 55, and then every other year or every 2 years after age 55.
Okay.
The American College of Obstetricians and Gynecologists recommend yearly mammograms at age 40. And so you can see the difference there. And the United States Preventative Task Force recommends every other year for women aged 50 to 74. So you see the wide range of recommend. Some say start at 40, some say 45, some say 50. But
in my book, perhaps it might be there's no harm in starting the earlier. I mean,
no,
at 40.
But it's cost again.
Oh, I see.
You know,
Okay.
again, it comes down to, is it a cost-effective thing to do? And where we are in Antigua versus where they are in the rest of the world in terms of what they spend on healthcare.
Which one of these different metrics or different recommendations is followed here in this country?
I think it varies, again, depending on
the
whether the obstetricians, the general practitioners.
Okay.
Generally, I start at age 40, but we tend to do twice, every other year, examinations. Again, it should vary depending on the person's risk. If they have a family member with breast cancer, a sister, a mother with breast cancer, particularly at an early age, they should start, some of them even earlier than 40. You know, and their history. If they had breast cancer at a younger age, then we're going to screen them every single year. You know, if they have a family, a sister, a twin, anybody like that, you know, we're going to screen them on a yearly basis.
In the case of, you touched on the fact that for prostate cancer, a first-degree relative, i.e. brother, father, son, if you know, one of them has, is it the same for example, breast cancer in women?
Yes, it is.
So same
it
thing.
does increase the risk, absolutely. If you're, you know, they definitely do tend to run in families sometimes.
Okay. Right.
But there are some different recommendations, as I said, for breast. And again, I know these topics were covered by previous speakers, so I really want to focus on the next two that we're going to talk about.
Yes, so let's go into those now. Right.
So colon cancer. And this now, we've done breast, cervical, which apply to women, prostate, which applies to men. These next two, colorectal and lung cancer, apply to both men and women. It's the second leading cause of cancer death in the USA. About 1 in every 20 persons will develop colon cancer at some point. 90% of the cases are in people over age 50. They used to recommend that we start screening for cancer at age 50. They've recently changed that and made it age 45, because more and more we are seeing younger people with colon cancer. And that trend, I think, is here in Antigua as well.
Wow.
Now, I see a sort of skewed, because I do a lot of colonoscopies myself, and I see a skewed population, but I am seeing younger and younger people with colon cancer. I can think of a couple of people.
What's the youngest you've seen?
42. But I think there have been people who's in their 30s here. Actually, I think there was one young lady at 26 that I'm aware of.
Colon cancer?
Colon cancer,
Wow.
yeah. But I've had a couple of them in their 40s, fortunately, who have done well. But I can think of, just in the last 2 years, at least 2 people under the age of 45 with colon cancer.
And that's, of course, a very aggressive kind of cancer, most times.
Well, you know, that interesting...
Depending on when you catch it.
With colon cancer.
Right.
Colon cancer starts as a polyp in the colon. And these polyps, not all of them, but some of them can go on to form into a cancer. It takes about 8 to 10 years for that to happen. And so if you follow the recommendations for colon cancer, if you find a polyp, then we change. The recommendation changes. Instead of 10 years, it's now 5 years or 3 years, depending on the stage of the polyp. But you can remove the polyp right there with the colonoscope, and that way even prevent the person from ever developing colon cancer. So it's a little different than a mammogram, which is finding a cancer early. We're now trying to find colon cancer before it ever even gets a chance to turn into colon cancer. The recommendation is starting at age 45, and we're talking about colonoscopies here. There are other screening tests that are available. Unfortunately, not a lot of them available to us here in the Caribbean. But the recommendation is still we're dealing with colonoscopies. And if it's good, you're good for 7 to 10 years before you need to do another one. Or every 10 years. You know, so it's not a test that you need to do every year. But it is a disease that is here. Being black is a risk factor for having colon cancer.
As is the case with prostate cancer.
Correct. You know, but it's definitely, you know, they list it as a risk factor for colon cancer. Just being black is a risk factor for colon cancer.
And you can do and people can do nothing about that. Absolutely nothing about it. Yes.
If you look at the trend in the United States, the death rate from colon cancer is falling. And it's fallen because of the advent of colonoscopies. You have over 1 million colon cancer survivors living in the United States.
Good.
You know, it is. And we have a lot here too.
Excellent.
You know.
How is some people say they're a little bit afraid of the colonoscopy. I think it's a little bit uncomfortable and can be painful.
Shouldn't be. It should be done with sedation and adequate sedation. In this day and age in medicine, there's no reason for anybody to be in any pain pretty much for any procedure. There are ways, you know, it just takes effort to do it. And so most of my patients, and I would imagine, hopefully most of the patients in Antigua who are having colonoscopies are not in any pain or discomfort having the procedure.
Okay, there you go. All right, let's go on to our next slide now, Doc, because you're focusing attention on 2 particular cancers. The first one being colon cancer.
Right. So these are the various societies and their recommendations. American Cancer Society, tests that detect polyps and cancer. A flexible sigmoidoscopy is like a half of a colonoscopy.
Oh, I see.
You can do it, and it can be done without any sedation. But it doesn't cover the entire colon. We used to do a lot of them, you know, when I was training. Then they went away from it because they felt they were missing too many. And now they're sort of going back to it and saying, well, look, you know, this plus an extra test, a fecal FIT test, which is not up on there. Mm-hmm. There are other tests that we can use. There's, you see the other ads for on TV for Cologuard, for example. Problem is, by the time we get Cologuard here, send it back up to the States, it's more expensive than doing
a colonoscopy. Oh, I see.
And so we haven't reached that point yet where that is something that is easily doable. Okay. Although I truly believe that the best test is the test that a person will actually do. It'll be nice when the price comes down so that we actually start doing them here in Antigua. If the test is positive, you still have to go on and do a colonoscopy. But I think the best test is the test that somebody will do.
So the ones that are available here, Doc, are the colonoscopy.
Mm-hmm. And a stool for occult blood.
Sorry?
And a test called a stool for occult blood.
Oh, I see.
Which is where we test 3 different stool samples for blood. Unfortunately, that picks up only about 20% of the polyps or cancers. Mm-hmm. And so I tend not to use it because I think it gives people a false sense of security.
So the best one that you'd recommend would be the colonoscopy?
Colonoscopy, here. You know,
which is available here?
Which is available here,
okay,
yes.
Good, excellent.
The other groups, you know, recommend colonoscopy when it is available. Mm-hmm. The United States Task Force recommends that we start at we do from age 45 to 75. They cut off at 75 because the life expectancy of a person after 75 is not 10 years.
Yes.
You know, and so they say, okay, after age 75, for routine screening, different if somebody has a history or other problems related to the colon, but for routine screening, can do it at 75, but don't do it again after that, because the chances are something else will kill them other than...
Right. In other words, you would have reached the point at which you exceeded your life expectancy, in other words.
Right.
Because the average life expectancy in the world is 72.6 years, the average across. So beyond 75, you're pretty much on borrowed time based on that metric. Mm-hmm. Right. And of course, if you live much longer than that, you're considered to be very, very blessed and highly favored. Doc, there's another one that we're going to go to, but before we go to our next one, we're going to take our next break here. You're in tune with House Calls, where this is fascinating information. We almost didn't want to take the break because of how riveting this is. Dr. Jason Belazaire, specialist in internal medicine, is walking us through, as I said, the causes of death, some of the causes of death which have, been very, very popular in this country and across the U.S. and so on, and how you can minimize your risk, what you need to do. He touched on the issue of diet and exercise earlier, but with some of these cancers, the screening issues. We're talking of living longer. The program is called House Calls. The program is sponsored by Sagicor with the kind compliments of Pink Mongoose who are responsible for our extraordinary floral collection this evening. Another one, which is absolutely taking your breath away. And of course, because it's the time of Easter, there's of course the Easter egg somewhere in there as well. So you're tuned with House Calls. We're also having with us as a partner, a valued partner, is A.G. Morgan, ensuring that we're sartorially elegant. We thank A.G. Morgan and Pink Mongoose, as well as Sagicor, our title sponsor. When we come back, we zoom in on lung cancer. We finish up on colon cancer, colorectal cancer, then we go to lung cancer. We will have your questions and feedback later in the program, in about another 10 minutes or so. So have your questions ready for Dr. Jason Belazaire. When we come back, stay with us.
I had a really good time tonight.
So did I.
Life moves fast. Be prepared with Sagicor. Learn more at sagicor.com.
I had to go to work in the morning before I go to school.
Okay.
Do a lot of work.
This week on Conversations, we speak to Sir James Carlisle. Join me, Natalie Clark-White, for Antigua and Barbuda's prominent people stories, and be inspired.
Let's get social. We're ready to connect with you. Find us on Facebook. Do you tweet? We do. Send us a tweet. Connect with us on Instagram. Keep up to date with news and more at www.abstvradio.com.
It's the return of GIS Presents, Monday evenings at 8, just got better. So join us for an exploration of how government institutions, policies, and laws work to serve you. That's every Monday at 8, right here on your station, the nation station, ABS.
Sunny Sunday music to chase away your night blues. Neo soul mixed with a whole lot of jazz. Why not? Join me every Sunday evening from 6 to 10 p.m. and let's paint music in the night air. Press the refresh button for a new week. It's Natalie Clark-White. That's me, Nat C, ABS 90.5 FM, the art in soul, and all that jazz.
With House Calls, our guest, the doctor in the house this evening, Dr. Jason Belazaire. He's walking us through how to live longer. As I said, the average age, life expectancy across the world, 72.6 years. So how do you ensure that you not only reach that average life expectancy and exceed it quite easily, but also how do you ensure that you live your healthiest possible life, that you are well? That's what we're focusing on this evening. Dr. Belazaire, so you're kind of zooming in on two cancers. We touched on one just before the break, colorectal cancer. Let's talk with us for finishing with that, please, and then we go on to the other one.
Well, the other one is lung cancer. And I wanted to talk a bit about lung cancer because it's not something that gets talked about often. And we weren't able to screen for lung cancer for a long time. Lung cancer was a death sentence for a long time. The difficulties with lung cancer is that the symptoms of lung cancer don't appear until late in the disease.
Well,
until recently, we haven't had an effective test for lung cancer. We tried studies for years doing chest x-rays on a yearly basis to see if it would let us pick up cancer earlier and save lives. And unfortunately, it didn't. There really was no benefit. There was no change in the lung cancer deaths using chest x-rays to screen people with lung cancer. What we do now is do something called low-dose lung cancer screening. And it's something that I'm trying to incorporate more and more. It's only for smokers. Mm-hmm. It's not for people who, who do we screen for lung cancer? we screen people between the ages of 50 and 80. They have to be a current or a former smoker.
And that's on our next slide, Doc, right? Excellent.
Correct. When we first started screening, we were doing people with a 30-pack year smoking history. So what is a pack year? If you smoke 1 pack a year for 30 years, you have a 30-pack year smoking history. If you smoke 2 packs a year for 30 years, you have a 60-pack year smoking history.
I see.
So you must have at least a 20-pack year smoking history, just 1 pack a day for 20 years. And you also must have quit, or if you're not currently smoking, must have quit within the last 15 years. Anything more than, if you're 15 years out from smoking, we don't recommend that you screen, because your risk is almost by 15 years back down to where it would be had you never smoked.
I see.
You have to have no symptoms of lung cancer at the time, which is a new or changing cough, spit coughing up blood, or any worsening shortness of breath, or any new change in your respiratory patterns. Because if that's the case, then we want a full dose CAT scan of your lung to evaluate you for lung cancer. The low dose, the screening, is done on a yearly basis. These people who fall into that category, which is myself, because I quit smoking 8 years ago and have more than a 20-pack year, so I have to do it on myself.
Yes, indeed.
But it's a yearly scan, a CT scan. Now, CT scans involve radiation. And so these are protocols developed with low doses of radiation, about the equivalent of about 12 X-rays. And it's done once a year, every year, to minimize your radiation dose. And when you look at the data, it's really quite phenomenal, because you can pick up things that are really small. Now, most of the things that you pick up on the scan are not cancer, but you come back the next year, we measure the size of it again, the year after that, and sometimes it takes 3 years of doing this before they see something that's increasing in size that's worrisome enough that they may want to go after or take, you know, or remove.
Yes.
But your only hope really of surviving lung cancer is to find it at an early stage. And the problem with X-rays is by the time we see it on an X-ray, it's usually stage 3 or stage 4.
Wow.
You know.
How do you catch it early?
Do the low dose scans of the lung. That's what we want to do. We want to find it early, much smaller at an earlier stage.
Starting at age 50.
Starting at age 50, yeah.
Are you, based on your practice, and especially in this country, have you been seeing younger people, younger than 50, with lung cancer?
I can't think of any. We see a lot of lung cancer. Unfortunately, they don't do well, because by the time we haven't really been doing screening for lung cancer, and by the time we find them, it's too late. Still a lot of young people. When I say young, I mean people in their 50s, 60s with lung cancer, and we have great difficulty even, you know, treating them and getting, because we don't have, you know, cardiothoracic surgeons here who would go into the lung and remove the lung and stuff, or the part of the lung, or remove the tumor. But we have to start somewhere. You know, we got to start. You're never going to progress unless you do the work. And so trying to get the work done so that people who are smokers, you know, no, for smokers, we don't want them to continue to smoke and use this as a, you know, as a sort of excuse to continue smoking.
Yes.
That's not what we're trying to do, or to give them a false sense of security. But it's the #1 killer, cancer killer in the, you know, in the United States. I can't say here in Antigua because I don't have that information to prove, but it's certainly in the top 3 on the list of lung cancer, of cancer killers in Antigua. And so if there's something we can do about it, we ought to try. And
Absolutely.
so
Absolutely.
that's what I want to get across. In the old days, it used to be 3 things in women: cervical cancer, breast cancer, colon cancer. And in men, 2 things: prostate and colon. But we have to add that 4th screening test, particularly for our smokers and even former smokers.
In terms of the risk factors for this one, does it also include, apart from being over 50, sorry, does it also include, being black?
Can't say that, no. Smoking is really your primary risk factor for lung cancer. You can get lung cancer without smoking. You can get cancers that spread to the lung as well, but this is not for cancers that have spread to the lung. This is for looking for cancer in smokers, either current or former smokers.
Okay, we're getting to the end of our slides, Doc. We want to go over to the others quickly. But this has just been extraordinarily absorbing information this evening about ensuring that you are able to live longer. All of this information is geared towards that. 72.6 years, think about that as the average life expectancy around the world. Some of the advanced economies, advanced countries have life expectancies in the 80s and so on. I mean, other countries which are, middle income, low income countries have much lower life expectancies, but the average is 72.6 years. How do you ensure that you actually at least reach the average and live a healthy life, which is characterized by wellness? Doc, back over to you in terms of the other slides.
Who benefits from screening for lung cancer? The benefit of screening is detection of lung cancer when it's curable and a decreased chance of dying from lung cancer. That's the benefits. What are the risks? The risks are finding a nodule or a spot in the lung that is not cancer. Most of the nodules, as I said before, that are seen on CAT scan are not cancer, but it may require additional testing. Depending on the size, generally that's how we decide what we're going to do, is the size of the nodule will direct where we go from there. Okay. And then of course there's false negatives. A negative screening doesn't mean that you don't have or you can't get lung cancer. These screening tests for lung cancer are done on a yearly basis. As I say, low dose lung cancer screening on a yearly basis.
All right, there you go. As I said, still have your questions because we're going to get to your questions a bit later on. So, of course, on Facebook and on telephone, we'll get to that very, very shortly indeed. Doc, I still think you have a few other slides to look at.
Well, just the other things. What are the risks as well? Radiation exposure.
Right.
The low-dose CT is about 20 to 25% of the radiation that you would get with a normal CAT scan. And that's the whole point, is you don't want to irradiate people unnecessarily. Right. So it's different. If we think that there's a problem in the lung, we're going to do a regular CAT scan. If we're just screening for cancer and that's our primary purpose, and there are no other symptoms, we're going to do a low dose to try and cut down on the amount of radiation. And obviously there may be a cost for additional scans if there are positive results, if there's anything else that we need to do. Okay. I definitely think it's a worthwhile thing to do. What you can expect, if we go to the other slide there, it just has a picture of a CAT scan machine. A lot of people are afraid of CAT scan machines. As you can see, that's a typical CAT scan machine. It's open on both ends. It doesn't cause a ton of claustrophobia because it's pretty small. It's like a donut, If your head is in, your legs and the rest of your body are out. So it's nothing to be terrified. For the low-dose CAT scan, we don't use any intravenous dye. We don't have to put in any lines or anything like that. A lot of scans that we do with injection of dye so that we can better see things on the CAT scan.
In terms of contrast.
Right. Contrast. We don't use contrast for the low-dose lung cancer screening.
Okay.
And it literally takes less than a minute to have it done.
And this is for this scan is used for which types of cancers?
This is just for lung cancer.
Just for lung cancer.
This is just for lung cancer.
None of the others.
I mean, we use CAT scans to help us with a lot of other things. But we don't do, it doesn't help you in breast cancer screening. It doesn't help you in cervical cancer screening. If you develop cervical cancer, by sure you're going to get a CAT scan to stage you, make sure it hasn't spread, those sort of things. Right. But in terms of screening, no. The only one we use the CT for screening is lung.
Okay, all right. The issue, let's just finish off these slides and then we'll come back to a few other quick issues to wrap up.
Lung cancer screening with low dose does decrease the deaths from lung cancer. It's not appropriate for everyone, which means if you don't fall into the criteria, if you haven't smoked more than 20 pack years worth, if you have quit for more than 15 years, you don't need to do it. It's only beneficial for those at the real higher risks for developing lung cancer. And it's not a substitute for quitting smoking, you know.
You wanted to make that pellucidly clear.
Yes.
That it is not a substitute for quitting. And just, we touched on it earlier, your encouragement to individuals is do not smoke.
Correct. But
and you're, I mean, an example of that.
I'm a former smoker, yes. And yes, so, but I also know, you know, how difficult it is to quit smoking and how enjoyable it is to smoke, you know. So I come from a different place, you know,
yes,
when
indeed.
dealing with lung cancer and lung cancer screening.
You had to weigh up the costs versus the benefits, and you had to look at the enjoyment of smoking vis-a-vis the significant health risks.
Correct.
And you would have been not forgiven being a doctor and knowing those risks for continuing to smoke.
Well, doctors are subject to the same vices that their patients are, you know.
Yes, indeed, indeed. But you took a very wise decision, a judicious decision to leave those pleasures, understanding that there are benefits to be gained from that. Doc, just before we start to take our calls and questions on Facebook, etc., a few other quick questions. In terms of the issue now, you touched on what we need to do to live longer. That's generally everyday life. Is there any sort of test that's general that can pick up more than one cancers? Or is each cancer picked up separately by a specific test?
Okay, there's no test that can pick up all of these cancers. There are tests that will pick up cancers at a late stage. For example, most cancers at a late stage, somebody's going to be anemic. Their blood count is going to be low. But by then, it's regardless of which cancer it is, if your blood count is low, it's oftentimes too late for us to do anything about it. You know, we still do routine blood tests, as we should. You know, I think everybody over the age of 40 should have yearly blood work. They should have their cholesterol checked, they should have their sugar checked, they should have their blood count checked, and their kidney function at a bare minimum. And then that's the kind of standard that I try and hold to in my practice.
Yes.
You know, maybe some might argue it shouldn't be every year, it should be every other year. A PSA, once you're over 45 on a yearly basis. I think these are things that, because these are things that can improve your life. It can make you live longer. If your cholesterol is high and you treat it, it can make you live longer. If your sugar is high, I can say, hey, and it's early, you need to lose some weight, you need to exercise, you need to eat right, so that you don't end up going on medications upon medications and then insulin and all of these other things. And you want to start early. You know, you want to pick these things up early so that people know. You know, we don't want to pick it up, you know, when your sugars are so high that you're going straight on insulin and these sort of things, because the damage has been done.
You don't want it to reach a stage where it's too late and there's nothing you can do. You can just do palliative care at that time. You're just, you know, essentially making the person comfortable. We're going to be taking your calls now, 462-2996, 462-2996. Questions on the expansive information that we would have gone through, any sort of clarification that you wanted from Dr. Jason Belazaire, for example, when to start these screenings and so on for the different types of cancers, please call us now, 462-2996. We'll also be getting your questions and your comments on Facebook as well, so we'll be able to get those in. If you're not able to be near a phone and you want to weigh in on the discussion, Facebook as well also is able to suffice. Doc, just before we do that, the issue now of what's the biggest concern that you're seeing in terms of a trend developing, or any sort of trends, sort of trend lines and trend analysis that you're seeing in relation to what people are doing that is really making them sick and really contributing to them not living longer?
I would have to say diet, lack of exercise, you know, are big on the list. I think when you look at our population as a whole, we are getting heavier, and there are problems and there's a price to pay for that. I'm also concerned with the amount of breast cancer that we're seeing. And I just seem to be seeing it at a younger and younger age.
What's the youngest you've seen?
Oh, the 30s, 20s.
20s?
Yeah, you know. So we're seeing it at a, at a younger and younger age. And, it's quite sad. I mean, I think the numbers are quite staggering. You see how much breast cancer there is in this country. And it takes a lot, and we're getting better and better at it, and the survival is getting better and better here in Antigua. But still, just the numbers are really quite staggering. Yeah.
Let's go to the telephone lines, Doc, and welcome our first caller this evening. Good evening. Thank you so much for joining us on House Calls. Please go ahead. Good evening. Go ahead, please.
Hello?
Yes, ma'am. Go ahead, please.
Yes. I would like to ask a question to Dr. Belazaire.
Go ahead, please.
Yeah. Concerning the prostate cancer protocols that you have, whether you're using digital examination or whether you're using PSA testing. If you do the PSA testing at the lab and the results come back high, then higher than normal, what would be your next course of action with that particular case?
Well, then, if the PSA comes back high, generally you want to know what is the cause. Infections of the prostate can increase the PSA.
Can I hear him?
Sorry, are you still able to hear us? Are you able to?
No, I'm not able to hear you.
Okay, Doc, for some reason, if you just speak up a little bit, it's okay, you're fine. It's just for you to speak up a little louder.
Okay. Can you hear me?
Yeah.
Can you hear me, caller?
Yes, I can hear you now.
Okay. So generally, when the PSA can be elevated for a number of reasons, it doesn't always mean cancer. It can be infection. So the doctor's going to ask you, well, what are your symptoms? Are you having signs of infection? Are you urinating often? They may then choose to do a digital rectal examination to see if your prostate is tender. If the prostate is tender, that might be a cause of infection. They may choose to put you on antibiotics for a period of time to see if the PSA comes down. If it does come down, then we know it's not cancer. If it returns down to normal, we know it's not cancer. If it remains elevated, then they're going to want to do a biopsy level, or depending on how high it is, they may just say, well, look, let's check it again in 6 months. But if it's very high, and it remains high even after treatment for any possible infection, they're going to want to do a biopsy to make a definitive diagnosis.
Okay. Okay.
Okay.
All right, thank you for the call. Really appreciate it. 4622996, as you said, that's the number to call us to, as I said, and it's all clarifications that you want. You said you're alarmed, perhaps that's a strong word, but you're concerned about the high numbers. You're saying you use the term staggering for the numbers in relation to breast cancer that you're seeing. Risk factors, what's relating to that? I mean, I'm pretty sure that it's a number of factors, but is there any specific one that you can mention that perhaps is a challenge?
That's a good question. I don't know what's driving the level of breast cancer that we're seeing. I only would encourage people to get screened, examine their breasts, get to know themselves well. And typically, when we tell a woman to examine her breast, we want them to preferably do it in the shower. Start from the nipple and work your way out in a circular motion. And make sure you go all the way up into your underarm, because the breast tissue goes all the way up into your underarm. Do it in both breasts. Get to know them. If there's a lump in there, follow it. If it's getting bigger, what I tell my patients is, think of a fruit or a vegetable. If something is the size of a pea, make sure it's the size of a pea next month. If something that was the size of a pea is now the size of a grape, you need to go see the doctor. Something needs to be done. Not to try and actually get a physical measurement, but to compare it to something that you know. so that you know, because most people can tell the difference between the size of a pea and the size of a grape.
Yes.
And to self-examine and not, you know, not to leave it or put it off. If there's something there that's of concern, get it checked out.
Okay, let's go back to the telephone lines, Doc. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
Hello, good night, Garfield. Good night, Doctor.
Good night. How are you?
I have a contribution to make.
Sure.
I am 78 years of age, and I did 2 endoscopies and 2 colons. In one of the procedures, I was told that there were a number of polyps in the system, which they were able to remove. I'm asking the question, at this age, should I do another colon or endoscopy?
Okay, so you had a number of polyps. Okay.
A number of polyps were diagnosed in my system.
And removed?
Yes, they removed them because they said they were...
Good.
There were several. Now,
Okay.
this was about between 10 to 12 years ago. Should I do another colon or endoscopy?
Yes, if you haven't had a colonoscopy for 12 years and you've had polyps, the maximum recommended time, if you've been diagnosed with polyps and benign polyps, is 5 years. You should have another colonoscopy within 5 years if you have had polyps. Now, endoscopy, which is looking down the stomach,
yes.
You need to, there's no evidence that an endoscopy is going to save lives. We don't do routine endoscopies going looking for stomach cancer because there's no evidence that we can find stomach cancer early or do anything about it. But the colonoscopy is different. If we find polyps on the colonoscopy, you know, sometimes we'll tell you to do it sooner depending on the size of the polyp or the type of polyp. Sometimes we'll give you up to 5 years. But until that 5 year is clean, if you do it in 5 years and it's clean, they may tell you, okay, you can go further. You can come back in 7 years or 10 years. But generally, if you've had polyps, we want to stick to 5 years.
Okay. So in my case...
But the other question is, how old are you?
78.
But if you've had 12 years, I would still consider, and you're in good health, I would still consider doing another colonoscopy.
All right. Could I make an appointment to have that done with you?
Sure, you're most welcome to.
May I ask your telephone number?
Sure. It's in all the telephone books, but it's 562-1160 or 1168.
1168. Okay then, Doctor. All right. Thank you for that advice.
Most welcome.
Really appreciate the call. Thank you so much as well. It's the 462-2996. That's what the program is about, ensuring that you're able to have the best possible advice. And as I said, advice right on cue. All right, Trudy Williams asks, good night, do you have screenings for throat cancer in Antigua?
Okay. There is, again, no evidence that we should screen for throat cancer because there's no evidence that we can necessarily find it early and do anything about it. It may well come in the future. If you have a concern with your throat, I mean, the typical concerns would be changes in your voice, soreness in the throat, that sort of thing. It's very easy to take a look down the nose and look at the vocal cords and see. And so it's a simple enough test, but there's no evidence that the incidence of throat cancer is not that high that we would recommend everybody at a certain age have a look down in their throat. But if you have concerns or symptoms related to an issue, then yes, it can be done.
Okay. All right, there you go, Doc. So, Trudy Williams, hopefully you got your question answered there. 462-2996, the number for you to call if you want to have any sort of information. We're getting a call coming in shortly. Doc, before we go to that call quickly, in terms of some of the other cancers, you did mention a few of the others. I mean, there are so many different ones of them, but the ones you mentioned are the ones that are the most important ones here.
Well, the ones that I mentioned are the only ones that we go looking for.
I see.
As doctors. We don't go looking, somebody comes in to see me unless they have abdominal pain, I don't go looking for pancreatic cancer unless they have symptoms of pancreatic cancer. I don't go looking for brain cancer unless they have symptoms of something in their brain. So it's not like everybody that comes in, you know, we do a CAT scan of their brain to make sure they don't have brain cancer, because it doesn't work.
Yes.
The ones that we mentioned are the ones that we go looking for, because those are the ones that we can change, that we can find early and do something about.
Okay. Look, let's go back to the telephone lines. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
Hi, good evening. Thank you for taking my call.
Sure, good evening.
I have a parent that's diagnosed with colorectal cancer, and he had radiostatic surgery. Now the bleeding has come back, and the doctor is recommending that he has a PET scan. However, this machine is not available here. What are the other options that are available?
So he has already been diagnosed with colorectal cancer.
Yes, he's 88 years old.
Okay. Now, I'm assuming it's an oncologist that's recommending the PET scan, and they're trying to direct treatment. The PET scan is a very good test at picking up if cancer has spread. It's not available here. The closest is in Puerto Rico, and their prices are pretty reasonable as well. I think there's another one in Trinidad. They're trying to locate if the cancer has spread, and it's better than just a regular CAT scan, because they use radioactive isotopes to determine where the cancer is. I don't think they're looking for any sort of at 88, any sort of surgical fix of anything, but they're looking to see if it has spread, because there's obviously some information they have has told them that there is a problem. Okay. But we don't have that equipment here, you know, and I always say yet, because we're going to get there one of these days.
Thank you for your help and for the information as well. I will follow up. Have a good evening, and thanks for this show as well. It's very informative.
Thank you very much.
Absolutely. Right. Thank you so much, caller. Really appreciate it. And as I said, I really appreciate the fact that you have been able to get practical advice and practical help in terms of the situation. 4622996. We'll be able to take perhaps about 3 or 4 more calls before we wrap our show this evening. Doc, the extraordinary information in terms of what you've provided to us this evening, we're hoping that this will change attitudes, change behaviors, because ultimately that's what this show is about. It's about being able to get people to readjust the way they operate. Again, you touched on the diet. What specifically about the diet? Because there's so many challenges with the diet, sugars, fats, salts, etc. What is the biggest challenge with the diets that you're seeing?
Well, I think the biggest challenge and what's driving our epidemic is bread, rice, potatoes, pasta, the high carbohydrate foods, as well as, you know, the sodas, the sweets, the juices. We got to get back to drinking water. Got to get back to drinking, you know, the non-heavily sweetened juices. Cutting down the carbohydrates, getting the weight. I mean, when I tell people, when people come, Doc, what's my ideal weight? They're shocked to hear what it is.
Yes.
Because it's usually a lot lower than
where they are.
Where they are, myself included. You know.
So you have work to do too.
Yes, I'm subject, as I say, to the same vices as my patients.
Indeed.
But, you know, definitely those foods. We consume a ton of bread, and I'm sure the bakers are not going to be happy with me, but we, as a population, consume a lot of bread, and it's putting us into some early graves.
What does that do? Just walk me through the pathology of that, in terms of what is high carbohydrate diets do in relation to, for example, not just cancers, but generally the things that are killing us.
Well, you know, the first thing you got to look at is how many calories should you be intaking on a daily basis? For most of us, it's somewhere between 18 and 2,200 calories a day. Now, if you have a person that drinks 3 glasses of juice a day, you know, or a juice and a soda and another juice later, each glass can of soda is about 200 calories. So that's 600 calories right there. You know, that's a third of your daily intake just in what you're drinking. You know, if it's more than that, it's even worse. Then you start to throw on, you have animal proteins, which are meat. Lean cuts of meat are fine because they're not very, they have calories, but they're not as calorie laden as bread, rice, pasta, potatoes, those carbohydrates, ground provisions, all very highly calorie laden foods. Now, you know us West Indians, we're not happy unless half the plate is exactly that. Rice, bread, pasta, macaroni, you name it. The other half is about 2/3 or 2/3 of that half is meat, and then there's a little wedge of vegetables.
Yes.
We need to turn the vegetables half the plate. Put the carbs where the vegetables are. Make sure the meats are lean cuts.
So we need to rearrange that plate.
The minute you start rearranging every plate of food like that, you are going to lose weight.
Wow. Extraordinary. Just rearrange your plate. Let's go back to the Facebook. Delhi Calvin, does heart arteries affect persons in the population? Heart arteries. Not sure what. Do you understand the question?
No, I don't really.
Okay. I'm wondering if the person meant heart disease or arteriosclerosis or something. Right. But I don't think they meant to say heart arteries. But I mean, generally, in terms of heart disease, I think generally the person was asking about heart disease. How big of an issue? Well, we saw from
you can see from our death certificate. And I think, you know, the problem with those, and they list them separately, but you have people who are diabetic and hypertensive. You know, you have people who've had a heart attack and a stroke. You know, you have people who are diabetic who have strokes. You have people who are diabetic who have heart disease. And so I tend to group that 46% of our deaths into one thing, because those are all similarly treated conditions that all lead to the same thing, which is blocking of arteries. And if you do that alone, you know, and you can eliminate or reduce your risk of that, you're going to live longer. That's what's driven the improvements that we've made in management of heart disease and hypertension and diabetes is what has driven our life expectancy to go up.
Yes.
Some of that goes to reducing our, you know, the incidences or early treatments of cancers as well. But a large part of that life expectancy improvement has come with our improvements in the treatment of heart disease, diabetes, these sort of things.
Extraordinary. When you think of it, and by the way, we'll be able to take perhaps about 1 or 2 more calls. If you want to call right now to have a quick clarification on something, please do 4622996, 4622996. It appears to me, Doc, that there are advantages and disadvantages of our development and our, just quantum leaps as a human civilization in terms of being able to make advances in medicine and health treatments and so on. So as I said, hundreds or thousands of years ago, life expectancy in the 40s, or if you live to 40, you were pretty blessed. Now we're talking about 72.6 years as life expectancy. But with that have come also on the downside. There's a downside risk to that because our diets, we're sedentary in our lifestyle, we don't exercise much, we're not active, we just sit for most of the day. That is the challenge. We have to change that. I wanted to just go back quickly to what you said about rearranging the plate. It's going to take a lot of public education on that because, as you said, most people, they're not satisfied until and unless at least half the plate is carbohydrate. What can be done about that? How do we change hearts and minds about that, Doc?
That's a good question, but it's education. And it's talking to people, and it's, you know, I stress this every day to my patients. You know, I don't believe in diets per se. I believe in trying to change the way someone eats. Because, you know, if they can do that and do it for 6 months, it's now part of their lifestyle. You know, this is how much vegetables they eat. This is how much carbs they eat. This is how much, you know, of the meats they eat. If you can get them to do that and exercise. You know, everybody tries to turn weight loss into rocket science. It isn't. It's what you eat versus what you burn.
Yes.
You know, if you eat more than you burn, you're going to put on weight. If you burn more than you eat, you're going to lose weight. And if you can tilt that balance so that you're, right now, you know, you're burning a little bit more until you get to your ideal weight and then let it even out, you know, we're in good shape. We all think that we got to lose, you know, the doctor tells you got to lose 20 pounds. I don't need you to lose 20 pounds in the next month. But if you can lose 20 pounds in the next year, that's less than half a pound a week. But if I can get you to do it for a year or even 6 months, I've now changed how you live your life.
Absolutely. Doc, let's go back to the telephone lines quickly for our penultimate call of the evening. Good evening. Thank you so much for joining us on House Calls. Go ahead, please.
Good evening, sir. Very good program. Good program.
Good evening.
But what I want to know, the doc spoke about the high in carbohydrates like rice, bread, and those things. What about the provision like dashing and plantain and ananas and are those things high? They high in carbohydrate? I mean, if you eat a lot of them, and I just what I want to know, if everything is not a moderation, can you please tell me something about that, please? Thank you.
Okay.
That's not.
You know, as I say, I believe in everything in moderation. You know, I don't believe that anything should be necessarily removed off the list of foods that you eat. You know, I just believe that there should be some moderation. Now, the ground provisions are calorie-laden foods. A lot of them are unprocessed, and so they're generally good for you, but not half a plate of it. You know, you got to make the vegetables the half a plate.
Yes.
You know, I don't have a problem with the unprocessed ground provisions. They're unprocessed. White rice is an issue. It's processed. Brown rice is better. You know, whole wheat pasta is better than regular pasta. You know, so there's something changes that we can make to make these things a little bit better for you. You can have rice, but, you know, try and make it brown rice, you know. If you're going to have bread, try and make it a whole wheat or a full bran bread. You know, it might be a little bit better for you.
White bread is bad.
Than
I don't know why people eat white bread.
No, I can't, you know, I still love white bread. I only eat white bread on a weekend, though. And a small amount. Yeah. That's the, you know, those are the things that I gave up to try and live a healthier life myself. I can't give up bread, but I might eat it once a week, you know, rather than on it becoming a staple of my diet every single day.
You're absolutely right. I like your pragmatism, Doc, the fact that you're saying, look, I mean, I have my vices too, Doc. It says all doctors have their vices, like their patients, but you can see what he's done to work on it. You see what he's practically done to work on it. Let's go to our final caller for the evening. Thank you so much for joining us on House Calls. Go ahead, please.
Hello, good evening.
Good evening, sir.
Doc. How are you?
Good evening.
Good evening.
Yes. Based on this discussion, there seems to be that only when a person is overweight that these symptoms start to come on. Is that true?
No, that's not true at all.
Because, no, let me tell you. No, I'm a slim person, right? And I love a lot of bread and rice and potatoes and things like that. And I have the same weight for years and years and years and over. So what is it that something has developed somewhere that I don't know about or something?
Well, no, but remember what I said. Weight is what you eat versus what you burn. Okay. Clearly, what you're burning, what you're eating, and that's why your weight is not changing. Now, that doesn't mean it's not only overweight people that get diabetes.
Okay.
We get people, you know, I have slim women who eat nothing but rabbit food all day who are on insulin, you know.
Okay.
So, you know, that's only a part of the risk factors, not necessarily all. And it doesn't matter really whether you're overweight or normal weight. That doesn't always change your risk factor for cancer.
So in other words,
slim people get cancer just like overweight people do as well.
So it's better to check, even though you think that you might be safe.
Correct.
Okay, sir. Thank you.
All right.
You're welcome.
Thanks for the call. I really appreciate it. I like the discussion. I like the exchange. You're saying, look, Your advice kind of doesn't work with me because I'm slim. I've been eating a lot of these things and I'm slim. But your retort was priceless, saying that, look, it's a matter of what you burn versus what you put in. I mean, what you put in versus what you take out in terms of burning it. Extraordinary discussion, really. And it's really about changing lifestyles, changing mindsets, changing approaches. And as Doc says, look, change the makeup and the formulation of your plate. If you do that, you'd have made a significant difference in terms of what you can do. Final comments, Doc, as we wrap this evening. In terms of what you want the persons who tune in on this program to do as of tomorrow. What do you want them to start doing as of tomorrow? One thing that you want them to take from this show, starting tomorrow, what's that?
I don't know if I can bring it down to one thing. Obviously, the advice for reducing your risk of heart disease, heart, stroke, diabetes, hypertension, the eating right and the exercise part, that reduces that 46%. Then we have the other 21%, which is your cancer risk. Get your cancer screening done that's appropriate for your age and other family history, etc. And that'll reduce 66% of what kills us here in Antigua, you know. And by thus, you know, you should live longer.
Extraordinary. And that is the motif of this program, about living longer. Not just living longer, but living healthier lives. Dr. Belazaire, it has been our absolute pleasure having you with us. I mean, this, as I said, a thoroughly absorbing discussion, thoroughly riveting in terms of what you've been able to show us about practical things that we can do. Really appreciate it. And we hope that our audience has really taken on board and assimilated, pun intended, what you've passed on this evening so that it is digested properly and it becomes an issue in terms of changing lifestyles. Because lifestyle diseases are what are killing us, right?
That's
it's
right.
a lifestyle disease.
It is.
Extraordinary. Dr. Jason Belazaire, as you said, is a consultant physician, specialist in internal medicine, head of medicine at the Celeste Bird Medical Center, joining us this evening with that treasure trove of information. Now you have a much better idea of what you need to do to live longer. 72.6 years, as we've indicated, the UN average, the global average for life expectancy. It has come a long way over the centuries because of advances in medicine and so on, but also it has been, there's been a little bit of a mitigation of that and a little bit of diminution of that because of some of the things that we've been doing, because we've actually advanced as a human society. We're no longer as active as we need to be, and we're eating too many unhealthy foods. We're not getting enough rest. All those things are crucial. That's been another edition of House Calls. Join us next week when we'll have another powerful edition. Let's thank our executive producer, Ernest Brathwaite, who's the brain behind this program, who has made sure that we've had assembled every week some of the best medical minds, not only in the country, but in the region. We really appreciate it. And to our production assistant, Mary Charles, to the entire team here, we really appreciate your company. See you next week for another edition of House Calls, and we'll have another perspicacious discussion on your health. Living longer, living healthier, being well. We thank our sponsors, Sagicor, Pink Mongoose, and H.G. Morgan. Until next week, so long.
Thank you.
Excellent. Good stuff now.
Thank you.